of Anatomy Corner. I'm Josh Shannon and will be your anchor for the morning. Today we have a very special presentation on hip dislocations. This injury presents most often in our under 35 population in sports-related injuries and motor vehicle collisions, and as falls in our elderly population. For the most part, this injury is easily recoverable after a little hip reduction, although there occasionally is some residual pain and discomfort to go along with it. Don't worry too much though, as we go to Bree in the Fields, who will teach us all we need to know about the anatomy of the hip.
Thanks, Josh. The hip is one of the most important joints in the body. As a ball and socket joint, the femoral head fits into the socket known as the acetabulum. It is firmly held in place by the acetabular labrum, a strong fibrous ring around the socket. The femoral bone is connected to the ilium by the ligamentum teres and iliofemoral ligament. As the strongest bone in the body, the femur needs plenty of rich blood to nourish the bone tissue. Blood is brought here by the ligamentum teres artery, and waste is taken away by ascending cervical branches. The extensive innervation of this joint makes it a nasty one to displace. The sciatic nerve passes posterior to the wall of the acetabulum. There are two types of dislocations, anterior and posterior. Starting with the most common, the posterior hip location is characterized by a flexed, adducted, and internally rotated lower limb. These are commonly caused by high-force trauma and motor vehicle collisions, falls from heights, and sporting injuries. An anterior dislocation is considerably rare. In this dislocation, the anterior hip capsule is torn and the femoral head is levered out anteriorly. It is characterized by a flexed or extended, abducted, and externally rotated lower limb. Again, these are caused by high-force trauma. Now back to Josh in the studio.
Thanks, Bree. I think we all feel a little less under the weather after that riveting segment. I decided I'm never going to play sports, drive a car, or walk again because it seems I could literally dislocate my hip doing almost anything. So next I'm going to talk about... Wait, what's this? This just in? An unsuspecting grandmother just dislocated her hip while shaking it off at the local fraternities? We'll cut to Zach, who's live at the scene.
Josh, you would not believe what just happened. It's a typical Tuesday morning on Rugby Road. Usually the elderly folks are dancing at fraternity houses, but this one lady just couldn't keep her stuff together. She fell off the table. Let's go check her out. First thing we need to figure out is the scene safe? Josh?
The scene is safe.
The next thing we need to do is you call 911. It's an elderly lady that has fallen down. There's lots of risks with that.
Okay.
So let's check out our patient over here.
My leg!
Hi ma'am, how are you doing today?
Not very well.
It looks like she's breathing and she's responsive. What year is it?
95.
That's slightly concerning. So the first thing we're going to do is palpate and look for any sort of gross deformities or hematomas, which could be significant of vascular injury. Oh wow, that feels like a baseball. That, my friends, is a femoral head. Looks like this is a hip dislocation. Now let's move down and look at our range of motion. Ma'am, can you move your leg for me?
No.
No range of motion at all, and we don't want to force anything because that could really do some damage. Now I'm going to check out sensation. Can you feel this?
No.
Josh, do you think she's lying?
Nope.
She can't feel anything. No nerve sensation. Nothing in her capillary refill. This is concerning. So 911 has been called. We got help coming our way. So now let's do some basic interventions. First thing what we want to do is splint the area so she doesn't move or aggravate it anymore. Here's your typical splint, the Eddie Bauer special edition green sweatshirt in their fall collection. You're going to lay it across here.
I don't think this is my color.
Oh, well, that's okay. The providers will bring us a better one. So we splint it back here, and then we wait for more help and make sure that the injury is not worsening, along with some ice, which is your typical first aid size bag of ice. Any smaller, it won't do. Any larger, it won't do. This is the right size.
Thanks, Zach. So it seems Zach just diagnosed that lady with a hip dislocation. So naturally we wonder, what can be done? Luckily for us, we have Dr. Hipster himself here to talk about treatment and recovery.
Hey Josh, this is Zach here, Dr. Hipster to be precise, and I'm going to talk to you about how to treat a hip dislocation after you bring it to the hospital. So, the first thing you want to do is do a repeat neurovascular exam to make sure that the blood flow and the sensation is going well and alright for the most part. Well, they did get their hip dislocated, so you got to get that fixed. And then we want to get some imaging done. So, we want to get an anterior-posterior view of their hip and pelvis, so we can either get a CT or an MRI. MRIs are too mainstream. So with CT we can get a great view. The next thing we want to do is reduce the sucker, and there are tons of techniques to pop that sucker back into place. The first thing we can do is the Alice method or the Captain Morgan technique. After reducing that, we will do another imaging study to make sure that we didn't cause any more damage and that the hip is back in its proper place. The next thing we want to do is keep it in traction and have them in bed rest for a while, no weight-bearing activity for about 2 weeks. But it can range from 2 weeks to 3 months depending on how bad the dislocation is. The reason we want to treat it as early as possible is because there are many complications that can arise. We can get avascular necrosis or AVN, which results in the vascularization not going to the tissue sites in the bone and causing necrosis, which means that the tissue breaks down and leads to other complications and even the possibility of getting a fake hip, prosthetic hip. Another complication is the sciatic nerve injury. The sciatic nerve is posterior on that leg, and it can create lots of pain if it's not treated early enough. The other complications, Josh, include recurrent dislocations or femoral artery damage. And the femoral artery is very important to any sort of blood flow to lower extremities of the body. So it's extremely important that we make sure there's no damage there. So in terms of following up, you want to get an MRI 2 to 3 months afterwards to make sure there's no surrounding damage and check for the signs of those complications like AVN and sciatic nerve injury. The other thing you want to do is aggressive rehabilitation. So in rehab, they're going to do stretches like this.
I'm on tonight, you know my hips don't lie, and I'm starting to feel you, boy. Come on, let's go, real slow. Don't you see, baby, I see it's perfect. Babe, I know I'm on tonight, my hips don't lie, and I'm starting to feel it's right. All the attraction, the tension. Don't you see, baby, this is perfect.
Make sure that joint has proper movement. But anyway, if you want any more information on hip dislocations, call 1-800-HIPS-DON'T-LIE. Thank you very much. Back to you, Josh.
Josh in with Anatomy Corner, and stay classy, UVA.